Have you worried about finding or keeping your family doctor? Have you spent hours in the ER waiting to get treatment? If not, you probably know someone who has. Most Canadians wouldn't be shocked to hear our systems under pressure. The evidence seems to be everywhere. According to the CD Howe Institute, Canada ranks 9 out of 10 when compared to other high-income countries in access to care, administrative efficiency, and equity. We rank last in timeliness. So what do other countries have to teach us about making healthcare work? And are there new fixes for those challenges we face? Canada's population is aging, and the number of people with dementia continue to rise. Could a new Alzheimer's drug be part of the solution? Welcome to The Rundown. Everyone agrees that Canada needs more GPs, that hospital wait times need to come down, and that people should have access to the right kind of care when they need it. But how do we get there? I got insight from Nadim Ismail, Director of Health Policy at the Fraser Institute, and Dr. Danielle Martin, Chair of the Department of Family and Community Medicine at the University of Toronto. Nadim, Dr. Martin, thank you so much for joining us on the program. Let's start with our healthcare system in general. I can assume that both of you can agree that the system is not perfect. There are things that need to be fixed. But Dr. Martin, let's start with you. What is working in our healthcare system?
Well, the first thing that's worth noting is that Canadians are actually quite healthy as a group. We live a long time compared to the average. And when you get really sick in Canada, you actually get terrific care. Canadians have lower rates of dying in hospital from stroke. We have excellent outcomes for cancer and cardiac care. And of course, we're covered, all of us, for a core set of services, doctor and hospital services, without having to pay for those services, which means that we have good equity of access when you can get into the system. And so there's lots to celebrate and lots to be proud of as a pretty healthy bunch.
Nadim, what positive aspects stick out to you in our healthcare system?
This is a healthcare system full of highly trained professionals who are doing their best for patients. Certainly, we see it on the outcome side. When you're going in with a very critical condition, the Canadian healthcare system is actually fairly good at dragging people back from the brink of death. And I think certainly some of the outcomes are quite positive. So in many ways, a positive system. And we do have a very high spending record, which is not necessarily a bad thing. It shows a very high level of commitment to a high quality healthcare system.
All right, the CD Howe report that we referenced earlier says that Canada ranks very poorly, 9 out of 10 in access to care. When we talk about access to care, that is broken down into a subcategory of affordability and timeliness. Dr. Martin, why is Canada so behind when it comes to access to care?
Well, let's talk about affordability because that's one that I think for many people is not intuitive. And the reality is actually that while we have very good coverage for physician and hospital services, we have lagged behind other countries in terms of our coverage of everything else. So in my practice, it is common for me to see people who don't have any coverage for their prescription medication, who don't have coverage for mental health services, who don't have coverage for physiotherapy. And so this question of affordability crops up in the lack of breadth of public coverage for a whole lot of services that are a critical part of modern medicine.
Nadim?
We have to remember, of course, that Canadians have some of the longest waiting lists for access to healthcare in the developed world, in spite of the fact that we have some of the highest health spending in the developed world. So we're spending a great deal of money, and yet we have some of the worst waiting times in the developed world, wait times that reach a record length year after year. And that high spending constrains our ability, of course, to do other things. So I think it's easy to point and say government's not doing enough, but the reality is government is doing a lot of things very wrong.
What other countries are we talking about? Who are we comparing ourselves to?
Well, let's look at other developed nations with universal access healthcare systems, the Netherlands, Germany, Switzerland, where they have very good access to primary care, to emergency care, to specialist care, to an elective surgery. Shorter waiting times in each of those areas, much shorter than Canada's, but even other nations that spend a lot less than we do and do better, like Australia, where they have shorter wait times and a lower level of spending. So Canada is not unique in having a universal healthcare system, but we are unique in having this incredibly long wait times experience.
Dr. Martin, let's talk a little bit about other aspects of our healthcare system. What areas do we look at that are holding us back in terms of competing with some of those other nations?
Well, I think one of the few areas where Nadim and I might actually agree on this is that even in areas where we've got these highly trained professionals, wait times are often long because we're not doing a very good job of coordinating the resources that we have. So, when I see a patient in my practice who needs a hip or a knee replacement, for example, I have very little way of knowing who could see that patient most quickly, and we don't have a coordinated system of getting people in with the next available provider in their region. And so we find actually that not only are wait times long in general, but they're highly variable by region and even within each province and territory. And so there's a lot that we could be doing to better coordinate those services so that when it's determined that what a person needs, for example, is to see a neurologist, that they're given the next available appointment with the next available neurologist at a convenient location in their region who can deal with their issue. And there are lots of examples in some of the countries that Nadim names, and even in Canada for some kinds of services. So, for example, what we see in Ontario in our cancer care system, I don't refer to Dr. So-and-so radiation oncologist. My patient, when they have a new diagnosis of cancer, is seen in a regional cancer center by the next available expert who can deal with that form of cancer. And so those things are all centralized. The same is true for cardiac care. People aren't waiting to see a specific individual. They're put into a single common queue and seen by the next available provider. And actually, those are some of the systems where our outcomes are the best and our wait times are the shortest. So there's a lot that we can do even before we start talking about spending more money, whether it's public money or private money, to coordinate better the resources that we've got.
Nadim, I'll get you to respond to that, and also what else do you think is holding us back?
I think Dr. Martin makes a great point, and certainly when we look at the experience of Saskatchewan, where they reduced their waiting list from the longest in the country to the shortest in the country, we see that coordination of care and that central intake was actually a key piece of the process. But we also have to remember, not only are we spending more than everybody else, and not only are we waiting more than everybody else, we have some of the fewest physicians, medical technologies, and hospital beds in the developed world. This is a healthcare system that's fraught with lack of access, with a capacity issue that needs to be solved. And it's not a money problem. The question is, I think, how do we get more money, more value rather, for the healthcare dollars we're already spending? How do we get better access to services? And I think if we look at those other developed nations that are doing a better job, we just see a different set of policies in place. We see a larger role for private entrepreneurs in the private sector to bolster capacity. We see different financial constructs to lead to a much better overall healthcare experience that in total is more affordable for patients and far more equitable. I note Dr. Martin talked about equity in the Canadian healthcare system. We're mid-pack to below average when it comes to measures of equity in healthcare.
Nadim, let's stick with you. You mentioned some policies there. Give us some examples of some nations and some policies right now that you're looking at their healthcare system and being like, wish we had that right now.
Well, let's come back to that C.D. Howe report, which was largely built on the Commonwealth Fund study, looking at developed nations with universal healthcare systems. The very best systems when it comes to access have private competition in the delivery of universally accessible services. They have private competitive insurance. The private sector is not an enemy of the healthcare system in these nations. It's a valuable partner in delivering better universal access healthcare experiences. That's true in Australia, Germany, the Netherlands, Switzerland. The top performing nations are all doing this. Canada is behind in involving the private sector in our healthcare system.
Dr. Martin, when Nadim says private, I see a smile on your face. For some people, when they hear that word with healthcare, there is a reaction. I want to get your response on what Nadim had to say there.
Well, I mean, I think, from my perspective, it's a smile because, those of us in medical education are working overtime right now to train more doctors than we've ever trained before in Canada, because I think it's true that our physician to population ratio in Canada needs to be higher. And there's work underway to train more nurses across the country, et cetera. But part of the dilemma that we face that I think it's important for people to understand is that given that we do have shortages of healthcare professionals, and those shortages, by the way, are global, the World Health Organization and other global multilateral organizations have declared shortages all over the world in all kinds of areas. If we open up for private entrepreneurship, what we often find is that we're pulling those scarce resources out of the public system and into these other models. So I think we have to be careful about unintended consequences here. It may be that a job in a private surgical clinic is attractive to a nurse, and that nurse then leaves the public hospital to go and work there. And what happens then is that the understaffing and the wait times in the public hospitals and the public system actually get longer. And so we have to look at the whole thing as an ecosystem. We can't just pull one aspect of another country's healthcare system out and say, well, they have a bigger role for the private sector, therefore putting the private sector into the Canadian context would make things better. There's lots of reason to be concerned that actually it would make things much worse.
Nadeem, I'll get you in for a quick response, and then we'll shift over to Ontario here.
Certainly, we have an overall manpower shortage. We don't necessarily, relative to international averages, have a nurse shortage, but we also have to remember we have unemployed surgeons in Canada who can't find surgical placements. We have surgeons willing to do more surgical time who can't get access to the public operating room. We have nurses leaving the public system because they're unwilling to accept the working conditions and simply leaving the profession or working in the United States. In spite of the fact that we have very few professionals, medical professionals particularly, relative to other countries, we have spare resources in this country that we can tap and make much better use of than we are now.
All right, closer to home, the Ministry of Health in Ontario says it's hit a major milestone by reducing the Healthcare Connect waitlist for primary care by 50%. Dr. Martin, that seems pretty significant.
Hallelujah. I mean, I couldn't be happier to see the wait list for primary care in Ontario beginning to come down. And I'll say that this is what happens when we declare a priority. And one of the reasons why the government of Ontario declared a priority is because our politicians were hearing it at the doors. People saying to them, how is it possible that I can't get a family doctor? Why am I having to run around and beg and plead and ask my aunt if her family doctor will take me, et cetera, when we all feel that access to primary care should be a right, and it should be easy to access a primary care team in my neighborhood, just like my kid can go to the public school. And so we are beginning to see movement on that list, in part because government has invested, new teams are being built, new doctors are being trained. We've streamlined access for internationally trained professionals to come into primary care. But the other thing that they did with Healthcare Connect was they cleaned up the list, because as you know, when the list is uncoordinated and people have been sitting on it for a long time, it turns out people have moved, people have left, people have found a family doctor in the interim. There's all kinds of things that people are on multiple lists, which we see actually all over the Canadian healthcare system. People on 3 waiting lists for 3 different MRI machines, and then they fail to show up for the other 2 because they already got one someplace else. So this lack of coordination is a major factor in the length of our wait list, and it is something that you can reduce the wait times just by cleaning up your data. But in the case of primary care, we have also begun to reduce the wait times because we are investing effort and energy and money in trying to turn the system around. And nothing could make me happier.
Now, just to catch our viewers up, the province committed to connecting 235,000 people that were on the Healthcare Connect waitlist as of January 1st, 2025, to either a family doctor or a primary care team by spring 2026. So, Nadeem, with that, my math, I think I'm all right here, 118,000 Ontarians connected with a primary care team. It's not insignificant, is it?
No, and certainly very positive for 118,000 Ontarians, certainly positive for those connected to them. This is a positive step, but it's a very political statement. It's half of the people who are on the list at January 1, which is all of 250 odd thousand Ontarians, where the college is saying there's over 2 million without a doctor. We know in 2024, 300,000 Ontarians left emergency rooms when they needed care because they couldn't get access to the healthcare services. 10,000 died on a waiting list in 2023, 2024. So it's a very small gain in a system that's doing quite poorly, but it is certainly a positive gain for 118,000 Ontarians, without question, a positive shift for them.
Well, and I would say actually that I mean, just because people die while on a waiting list doesn't mean that they die because they're on a waiting list. People die all the time for all kinds of reasons at the same time that they're on all kinds of they're also doing lots of other things at the same time that they die. But I will say that, this question of access to primary care is not just an issue in Ontario, it's an issue across the country. And we all know that when you don't have a family doctor or a primary care team, nothing else works in the healthcare system. This needs to be a core priority for every single provincial, territorial, and the federal government across the country. People need to be able to expect to access primary care close to home. And that's not something that we're going to be able to fix anywhere overnight. But when a government declares a priority and the medical profession gets behind it and the people of Canada say, this is a priority for us, then we can start to move. And I think we are seeing the beginnings of that in British Columbia. We're seeing the beginnings of it in Ontario, in Prince Edward Island. There are lots of great examples of models happening across the country. It's not just going to be doctors. It will be interprofessional teams, because that's the model of the future, is doctors working in teams with nurses, nurse practitioners, pharmacists, other healthcare workers, in order to be able to serve a larger number of people with the resources that we've got.
Dr. Martin, you had mentioned fixes, so I want, in our last little minute that we have, make sure that we touch on some solutions. Nadim, what kind of best practices can we adopt when we look at those peer countries, whether it's Netherlands, Germany, the UK, Australia? Give me two solutions.
I think the answer comes back to getting better value for money. And again, if we look at 100% of the top performing nations, whether it's those nations with the best wait times experiences or the best outcomes from the healthcare process, performing better than Canada is, we see private competition, entrepreneurship, and innovation involved in the healthcare system. The private sector is not an enemy of universal healthcare. The private sector is, in fact, a partner in getting a high-performing universal access healthcare system, a system we're already paying for. And we certainly don't need to spend more money on healthcare. We're already a top spender. We just need to get the actual value for the dollars we're already spending.
Dr. Martin, you get the last word.
Well, we're in agreement that we need better value for money. And what I would say is, as a person working in the healthcare system, I don't want to see more competition. I want to see more collaboration. I want to see hospitals working together to make sure that when my patient needs something, they get the next available appointment in my region. And I want to see teams, not just of physicians, but of other healthcare workers, working together to take responsibility for the neighborhoods and the populations that we serve. It's that kind of collaboration actually that defines the delivery models in many of the other countries that are outperforming us. And I think that's what we need to see more of in Canada.
We are going to leave it there. Dr. Martin, Nadim, thank you so much for joining us on the program.
Thank you so much.
Thank you.
Almost 770,000 Canadians live with dementia today. That number is projected to rise to 937,000 by 2031. Alzheimer's disease is the most common cause of dementia, and currently there's no cure. Could lecanemab, a drug recently okayed by Health Canada, make a real difference for patients and for our healthcare system? For more, I talked to neuroscientist Saskia Sivanathan, founder and CEO of the Brainwell Institute and affiliate professor in the Department of Family Medicine at McGill University. Saskia, welcome to the program. How are you doing?
Good. Thanks for having me.
Well, we are talking about lecanemab. What do we need to know about it?
Okay. So lecanemab 101. So the brand name is Leqembi. And there's a lot of excitement around this new drug for a range of reasons. It's the first of its kind that really starts to get at the underlying pathology of Alzheimer's disease specifically. So the way lecanemab works is it binds to a certain protein that accumulates in the brains of people who have Alzheimer's disease. And that protein is called amyloid beta.
Okay.
And one of the hallmarks of Alzheimer's disease, and in most of the brains of people who have Alzheimer's disease, are these plaques made up of that amyloid protein that kind of clumps together.
Okay.
And it's thought that's what prevents the brain cells from communicating with each other. So the way lecanemab works is it goes in, binds to that protein, and removes it from the brain. And what they see is that there's a slowing of the cognitive decline, which is one of the main symptoms of Alzheimer's disease. It slows it by several months to up to a year. So that's how lecanemab works.
Are we using it as a pill? Is it an injection? How does it work in that way?
So it's not a pill.
Okay.
It is going to require IV infusion a couple of times a week. There's a protocol for it. And so it means that you'd have to probably go into a specific clinical site if you're eligible for it to get it. As well, you need to be monitored very carefully using MRI imaging. So
Why is that?
Oh, good reason. So first of all, in order to be eligible for lecanemab, you have to have a clinical diagnosis of early stage Alzheimer's or mild cognitive impairment. So I'll take a step back here and zoom back a bit, because dementia is the term that's being used more broadly, but that's really an umbrella term for over 100 different types of diseases. Alzheimer being the most common, but there are many others, Parkinson's-related dementia, frontotemporal, all of that. But this is only for Alzheimer's disease and early stage Alzheimer's. And you have to have amyloid beta pathology in the brain. So that's why the imaging, through the imaging, they can confirm if you have that pathology. And then they do need to monitor people who are on lecanemab, because there are side effects to it that require that kind of monitoring.
I want to make sure we're clear here. Not a cure, cannot reverse Alzheimer's disease.
Exactly, absolutely. It's not a cure, does not reverse Alzheimer's, but slows the progression. And it's the first class of drugs that is dealing with the underlying pathology of Alzheimer's, whereas all the other drugs that are currently on the market are more about the symptomatic management of Alzheimer's.
Is that why there is so much optimism? Or is there more to it?
Yes, there's more to it.
Okay.
I think there's more to it. So I'll get into it a little bit. I think the first is, it's been over 10 years since there's been any drug on the market for Alzheimer or dementia broadly. So, I mean, that alone is a big reason, right? And there have been a lot of high-profile clinical trials that failed, with a lot of money that went into it for Alzheimer's. So again, to have this first class of drug, big deal. The second is this is the first class that has received market approval to, again, get at the underlying cause, which others didn't. But the third for the controversy is the side effect. So it does have a side effect called ARIA, which is amyloid-related imaging abnormalities.
Spell that for us.
ARIA, A-R-I-A. It's an acronym, love acronyms.
Yes.
And basically what it means is that some of the people who do receive lecanemab have brain swelling and microbleeds. So this is the other reason why they need to be monitored very carefully through MRIs. But as we know, MRI infrastructure and access can be tough.
Okay. Eligibility. Who gets this when it's on the market?
Okay. So market approval is very specific. It's for adults. And the reason I specify that is because there are childhood-related dementias.
Okay.
This is for adults only. It's for mild cognitive impairment, which is an earlier stage of dementia that can lead to Alzheimer's, but not everyone does develop it. And it's for early stage Alzheimer's only. Now, that is very important as well, because it's often difficult to get the diagnosis.
Okay.
Yes, and we can get into that a bit later, but the other piece to remember is that you have to have amyloid pathology in the brain, hence the imaging.
Right.
And the third is that people who have a gene called the ApoE, and specifically the ApoE4, it's a variant of that gene, puts you at a higher risk of developing Alzheimer's. So they are ineligible for the drug if they have both of the variants.
Huh. Very interesting. Okay.
Yeah.
I want to talk, there's a lot of optimism, a lot of excitement around this. But there is also, you mentioned the side effects, but there's also a cost associated. Do we know what the cost is?
We don't. We don't know the cost yet. And Canada is actually the 50th country to approve. So we took our time.
Why?
A lot of different reasons. The process is very rigorous. And I think Canada likes to have its own data. Doesn't necessarily make decisions based on how other countries are approving. It was approved in the US and countries like Japan, et cetera. So the important piece about that, though, is that you have more real-world data. Because they've been approved and accessible in those markets, you now know how that drug is doing in those communities, and you have more longitudinal data. So that's important for how some of the decision-making might be made. Price-wise, in the US, it's priced at about $27,000 USD annually, only for the drug.
Okay.
It's not including the cost potentially of IV infusions and MRIs. Now, they do have a private system. Ours is a public system, so there's a lot of those pieces to think through as well.
Well, let's talk about it.
Yeah.
Will it be publicly funded?
We don't know, because that is a decision up to each province around how much they're willing to fund, whether private insurers will cover it or not. But this price piece has come up a bit, right? I mean, if it's $27,000 USD, what will that mean for Canadian dollars? But I often do think about other large conditions like cancer, stroke.
Right.
And, for some of those those drugs, it's comparable, if not more, for those treatment options. So I think when you're thinking about a disease like Alzheimer's disease, you're talking about a disease that has had really no other really good treatment options. You're living for, on average, 8 years with the disease. And the progression means that it's language loss, it's cognitive loss, functional loss, until eventually this person can no longer take care of themselves, right? They need 24/7 care. It's a devastating disease in many ways.
Well, if it's not publicly funded, how do people who do need it, that you mentioned how deadly it is, how will they get it?
It will likely be private insurance, if they have private insurance at that point, and if private insurers will cover it. So there's a lot of pieces to consider with the drug on that front.
All right. There are over 750,000 Canadians currently living with dementia. How do we ensure that when this drug does hit the market, Canada is accessible, they have the ability to get it when they need it?
Yeah. Well, I mean, it is very tight eligibility. So what that likely means is only a small percentage of people will even be eligible for the drug, likely under 10%. But the other piece to this is being diagnosed in a timely way. So we touched on that briefly, right? On average, it's taking about 2 years to get a diagnosis of dementia. That's a long time. Yeah. And that means that that window might close. And in order to really support that kind of accessibility, we need coordination and better clinical pathways. And you need more treatment options. This is just a first class of drugs. There's a whole pipeline that hopefully will be coming through. But we also know there are other treatment options that need to be available for dementia. And we just don't have that in our health system at all. There's really no coordination. You're kind of left on your own once you get the diagnosis to figure out what to do next.
All right. Well, let's talk about that. Aside from lecanemab, what are some other new treatments that are out there or that are in that pipeline that are giving you some hope?
So there's kind of three things. There's the drug treatment options. There's a whole pipeline, things that are targeting a different type of protein called tau that's also in the brain. Thinking about neuroinflammation, so different types of markers that are getting, again, at that underlying pathology of Alzheimer's and then broader dementia. So there's, I think, a lot of hope because a lot of those will read out, those clinical trials will read out over the next couple of years. The second are blood-based biomarkers. So these are much closer to getting to the market. And what they do is it means it's a blood test to be able to see if someone has Alzheimer's or other forms of dementia. Again, that's important because right now it's just a cognitive test mainly for being able to diagnose someone, which is really difficult, especially if someone speaks a different language, cultural nuances that don't get considered in a cognitive assessment. But the other pieces are rehabilitation therapy, which we now know is really important and supports slowing the functional decline, and then multimodal lifestyle options, so exercise, diet, and cognitive therapy, which in combination can also slow cognitive decline, and we don't offer any of those right now to people living with dementia.
Saskia, we're going to leave it there. Thank you so much.
My pleasure. Thanks for having me.
And that's it for us here at The Rundown. We're building the show for you, and we want you to build it with us. What issues do you want to know more about? What do you like or not like about what we're doing so far? Let us know. Send us an email at rundown@tvo.org or DM me on Instagram @jnjagannath. We'll see you tomorrow.